Good morning, dear colleagues. We are all living a difficult period trying to deal with the current outbreak of coronavirus. That's why I wanted to share with you this presentation, which summarizes the very last consensus for the management of colorectal cancer patients during the epidemic. It is based on the literature and on the experience of our Chinese and Italian colleagues. For sure, it's not evidence-based yet, because nowadays we only dispose of expert opinion. And maybe it can appear a bit drastic if you live in a country like here in Belgium, where the epidemic is only beginning and the health system is not saturated yet. But it can help us for next weeks when a health crisis will probably occur and define in advance a very useful protocol for the management of these patients. It can represent an advantage for us because don't forget that in other countries hospitals drowned under the wave of the outbreak. So let's start this presentation and see some general points. This exceptional situation results in loss of quality of standard treatment. We have to protect the patient from contamination, we must avoid to spread the infection, and we have to preserve the patient avoiding aggressive treatments. We will encounter a loss of availability of resources dealing with a bottleneck effect. As shown in the slide, currently we have entering in the bottleneck and we have to face a different population of patients with higher risk of morbidity because of delayed diagnosis and late presentation. Also, lately, cases will increase and facilities will be limited. So what we know from previous Chinese and Korean series about COVID-19 infection is that COVID-19 infection in oncologic patients is severe. They have 3 times higher risk of contracting infection, 5 times higher risk to develop a severe disease, 8 times higher risk of death. I put the accent on the fact that 75% of patients undergoing surgery or chemotherapy during the month before the infection present a severe disease. So, a tight timing of the surgical treatment cannot be achieved. On the other hand, we must achieve a kind of in-hospital social distancing to avoid spreading of the infection, trying to reduce recovery, to try to reduce visit, to try to reduce contact with the hospital. It is important to avoid aggressive treatments, so the standard care must be adapted, limiting high-risk situations as chemotherapy and surgery. The quality of the treatment that we can offer will be poorer and comporting higher risk of complication. So the risk-benefit ratio should be discussed. Basically, oral chemotherapy, when possible, and telecounseling should be promoted, and specific management has to be discussed in virtual MDT to define a tailored therapeutic plan and considering the level of gravity of current epidemic. So what would be the oncologic impact of delaying therapy? Well, consider that the tight timing of management is a quality standard and we cannot guarantee it nowadays. But in normal time, we deal with the waiting list at the operative theater, and to wait can, on the other hand, permit to select the good candidates and prepare the patient for surgery. Think about rehab and nutritional assessment. Nevertheless, the risk of a poorer treatment does exist. Anyway, in case of delayed management imposed by a public health crisis, we have to propose alternative therapeutic strategies to control the nutrition and to offer a psychological support. Few words about change in preoperative workup. We need for sure a good anamnesis, trying to identify risky patients, calling them the day before surgery, A CT test should be performed systematically when PCR is not available, and we should to treat suspected patients as COVID-19 positive patients. Let's talk specifically about the management of colorectal cancer. First, about the colon, we can say that the effect of delayed management is very poorly evaluated, but surgery within 90 days, essentially 12 weeks, seems to be proper with few impact on oncological results and mortality. In patients presenting early colon cancer and small tumors, surgery must be delayed depending on the general context and the level of the epidemic. In alternative, neoadjuvant chemotherapy can be proposed in the meantime, but then the patient has to come to the hospital. For advanced colon cancer, it is proper to propose a neoadjuvant chemotherapy using the Foxtrot trial protocol, and we delay surgery at the end of the epidemic. The oncologic impacts, risk of progression to occlusion, and immunosuppression caused by the treatment should be considered. Here is the Foxtrot trial design. It consists essentially in 3 cures of FOLFOX preoperatively. Surgery is delayed after 6 weeks, finishing with 9 cures of FOLFOX. The indication is T3-4 N0 to 2 M0 non-occlusive cancer. It permits a downsizing and downstaging of the tumor. In the study, we have more R0 resection and less R1 resection. Morbidity and mortality are equal, and there is non-significant reduction of recurrence. An option is to use Capox instead of Folfox or oral capecitabine alone as monotherapy for good prognosis lesions. Particular case is the occlusive cancer. In Chinese and Italian series, it has been shown that 70% of cancer presented occlusive during the epidemic, cause the patient wait to go to the hospital because he is afraid. It seems to be proper to perform a colostomy in this case, then neoadjuvant therapy and surgery after 4-6 weeks. Stent as a bridge to surgery is also an option. We can put it without anesthesia, but there is a risk of perforation. Attention has to be paid for ostomy cares representing a risk of infection for caregivers. For rectal cancer, the strategy is basically the same. For patients with early and good prognosis cancer, T1, 2, and 0, we have to delay surgery in function of the situation of epidemic. A short radiotherapy can be proposed in the meantime. For locally advanced cancer patients, a short protocol of radiotherapy, 5 grays 5 times with the waiting windows, should be discussed. The induction chemotherapy can be discussed as well, and the surgery can be safely delayed within 12 weeks, as we know from Rectal 6 study. The question for our patient will concern essentially patients who end the treatment in the first period of the epidemic, the patient who needs surgery. Surgery must carefully proposed for these patients depending on the phase of the outbreak and availability of resources. Induction chemotherapy could also be an option. Particular cases for the rectum, for example, the T4, it has been shown that it has a better response to radiochemotherapy based on the Rectal 2 study. We can propose the schema CAP 50 of radiotherapy is 50 grays and capecitabine alone, and surgery delayed within 12 weeks. We have to think about tumorectomy and watch and wait strategy. For metastatic cancer, first and second line resectable cancer, we have to delay surgery at the end of epidemic. We can do some chemotherapy instead, and less morbid surgery could be possible. All the rest, mono or B chemotherapy should be proposed. Oral chemotherapy with stable or slow-going disease is also an option, and if the disease is stable, we can discuss a break of 2 months. Let's talk about the postoperative management of this patient. For sure, it is mandatory to apply the ERAS protocol and fast-track protocols. We have to deal with the potential COVID infection postoperatively, and so we have to monitor the temperature, vital signs, and blood oxygen saturation. If infection is suspected, we take isolation measures. We have to perform a CT chest and PCR with eventual transfer in COVID unit. Criteria for removing the isolation status are normal temperature for 3 consecutive days, improving in respiratory symptoms, and improving images in CT chest, and 2 negative consecutive PCR from respiratory tract specimen 1 day apart. So let me spend just a few words about minimally invasive surgery, the laparoscopy. There's a paper published in Annals of Surgery concluding that laparoscopy could be dangerous in COVID patients, but also in other patients, the asymptomatic ones, because the gas of the pneumoperitoneum can spread the virus during the dissection with aerosol particles in the operating room environment and infect the surgeon and all the OR staff. Well, this is a study based on previous series showing that some virus, as HIV and HPV, from the patient can infect the OR staff through pneumoperitoneum. So first of all, laparoscopy should absolutely not be contraindicated. It remains the gold standard with less surgical complication, the good effect on cardiorespiratory function, and it improves recovery. But it has to be used carefully by expert staff, and maybe we should try to avoid high risk of conversion laparoscopy, and attention has to be paid in patients with pneumonia, in which laparoscopy is for sure contraindicated. As we don't really know too much about this new virus, we can accept to take special measures during laparoscopy, as operate in a room with negative pressure to avoid gas leaks using, for example, balloon trocar or smoke filters, to put an additional trocar to use the suction to aspire the smoke, and aspire all the pneumoperitoneum with the suction at the end of the procedure and before removing the trocars. Special trocar, like the air seals device providing a CO2 filter, can also be used. So, that's all. I hope this presentation can be useful for your current and future practice, so share it with your colleagues, and good luck, take care, and stay safe.